My name is Tyra Bryant-Stephens, and I direct the Community Asthma Prevention Program of the Children's Hospital of Philadelphia. Today we are going to train sites on how to expand the CAPP Home Visitor Program throughout Pennsylvania. Our other trainers include Carmen Perez, our Asthma Healthcare Navigator, and Natalie Bajin, our CAPP Resource Coordinator. Here's our agenda today. I'll talk a little bit about the CAPP expansion project, what we're planning, what we want to see happen. We'll then we'll do a deep dive into our CAPP home visits to talk about how we recruit, how we collect data, how we educate. Carmen will help with some of the education pieces and show us how to use the asthma medications and devices, and then we'll talk about next steps. CAPP was founded in 1997, and this was the result of my experience as a general pediatrician and as a medical director of my patients and our practice patients going to the hospital emergency room, even though we were providing state-of-the-art care at our practice. So my concern was that there was a gap between what we knew should happen and what was happening. And because of this, we started the Community Asthma Prevention Program in order to bring the community and the medical community together. Our goals are to improve access to and quality of asthma healthcare services for children, to improve knowledge about asthma among affected individuals and the general public, to make communities and schools more asthma friendly, to promote asthma safe home environments, which is what we're going to focus on today, and ultimately to reduce disparities in childhood asthma outcomes. Our targeted areas have been West, South, and North Philadelphia, and these communities are characterized by poor, predominantly African American and Latino residents. As you can see on this map, we have been over most of Philadelphia through the last 17 years, and we have in all these communities implemented a home visit program. Our building blocks are community partnerships. So for every project we do, we try to identify community partners. We find that that's essential to being successful in implementing any of our evidence-based programs. We also promote optimized asthma care. That is, making sure that everything we do is consistent with the National Asthma Guidelines, and everything that we do promotes that use for families. We research, so we study to see if what we do is really effective, if it really works, and then we advocate for sustainability of the programs that work. Our long-term impacts and outcomes focus on, at a patient level, is we want them to know more about asthma. We want to reduce asthma triggers in their environment. We want to reduce school days missed and parents' work days missed, as well as symptoms days, and ultimately reduce emergency room and hospitalizations. At the practice level, we look for improved use of asthma guidelines and change in physician behavior. At the community level, we look at asthma knowledge and awareness, and at asthma prevalence. And at the school level, we look at student knowledge, school professional knowledge, health visits data, and asthma prevalence. Today, we were going to focus on individual level changes in the homes of children with asthma. The CAPP expansion project, again, is funded by the Pennsylvania Department of Health, and the goal of this project is to take some of the lessons we've learned and the methodology that we use for implementing home visits in the community and disseminate it around the state. We are focusing in year one in 5 communities or 5 counties: Bucks, Delaware, Montgomery, Chester, and Philadelphia counties. How are we going to do this? First, we need to identify partner sites. So thank you guys for being one of our partner sites. And then once we do that, then we want to complete a needs assessment for each site. So that is finding kind of where you are and what you know, which we did with Rachel. We want to conduct training for staff, which is what we're doing today. And then we have the sites submit the proposal with timeline, budget, and budget justification. And then we want you to just start enrolling. You learn in doing in this, so once you feel trained, we would like for you to get started. And then what we would like to support you with is monthly telephone calls, so you can ask questions, we can talk about problems. Typically, what we do for our staff, for our team meetings is that we have our home visitors bring in the problem that they have, the individual problems. We discuss them at length. We talk about what are solutions if there's something that occurs urgently before we have those monthly calls. And obviously, you can call us at any time. And then at some point, we would like to observe you doing the home visits. So let's talk about our home visits. So we coordinate this home environmental management through referrals, and we have used our hospital's patient database, our community primary care providers also refer, school nurses refer. We do 4 home visits, and then we evaluate at baseline and then at a subsequent visit to determine whether there's improvement in asthma self-management skills. We look at the visual, we do visual assessments to look at the home environment to see if there's reduction in asthma triggers, and then we track health care utilization for those children who are enrolled. And we also give that feedback to clinical providers so that they know they're in our program, and we ask the parents to allow us to share even what we see in the home. So if we identify a trigger that we feel the provider should know about, then we want to share that with the provider. When we talk about lessons learned, the 5 C's of recruitment that we've learned that works is, first of all, communication. There has to be communication on all levels in the community, peer to peer, community health worker to provider, community health worker to school nurse, provider to provider. We try to keep that circle of communication open so that we can get as many referrals as possible from our partner sites. We try to involve the community. When we talk about implementing it, we have to many times adapt it to the environment. So you want to at least ask, you know, what works here, what works in this community, what are some of the issues that you might find in this community. We try to make sure that this is convenient. So our community health workers have to have flexible times that work for the schedules of the caregivers. Also, the interventions may have to be changed for an individual if there are some barriers. So, for example, if the family is, the caregiver rents and does not own her house, there may be some things that we could not do that we would normally want to do. And obviously, we have to adapt that for the family. We compensate them for their time, usually in the form of asthma supplies or environmental intervention supplies. And then we always get 3 contacts. One of the other lessons we've learned is when we have community health workers in the field that we want to have close supervision. A, because they're very autonomous. And I know you guys already do that, but you know that when you're starting out, that it's very important that you have someone you can talk to when there are problems. Also, we ask community health workers to report their schedules daily. We schedule regular ride-alongs with CHWs when they are in training. That is, the supervisor rides along and just makes sure that they're implementing the protocol correctly. We try to ask the community health workers not to make decisions in the field, but to bring them back to the team. But we do know that we're all, you know, human, and in the heat of the moment, you have to make a decision. But we do want to share that and pass it on with the rest of the team. And one of the things that we learned from community health workers is that definitely relationships are first. And that's why they're able to create such good rapport with families, because they focus on the relationship. But we also have to collect data. So it's really a hard thing to balance those, but it's important that we do that. And we appreciate that each community health worker brings their own personality to the relationship with families. And it's important to monitor sometimes for codependency. Our current community health workers are very experienced, but starting out, we did have to monitor for that, because of course we want to help people who are in need, and just have to make sure that we don't create codependent relationships. So how do we deliver it? We, again, train community health workers, and they need to be in the community, live in the community, look like the community. They deliver in-home evidence-based asthma education, environment mitigation, and we'll get to that training shortly. We review symptom diaries. Sometimes monthly, sometimes every 3 months, depending on the project, to help better manage asthma. And we promote self-management self-management of environment exposures by demonstrating medication use, asthma devices, trigger avoidance techniques, reviewing the asthma action plans, and connecting families to resources. Here's what we're proposing for the CAPP expansion. We're proposing 4 visits, hopefully over 4 to 6 weeks. One of the things that we've learned is that the longer you schedule them out, the harder it is to get them back. So what we usually advise our community health workers is the first time you go into the home to say, is this a good time for you? And then schedule the next 4 weeks for that time. If they say no, then they can change the time. And we'll have time for questions. I'm sure Carmen can give her insight as well. And so for the first home visit, we enroll. And enrollment in this study does include a caregiver survey, which you guys have a copy of that. And that survey has to be completed at the time of enrollment. We also review their medication just briefly. We want to look to see what they have. We write it down. We make sure that it goes along with their asthma action plan if they have an asthma action plan. If it doesn't match, then we advise the parents to call their provider to say, you know, what you have on the asthma care plan is not what I have at home. Sometimes it's an insurance issue. Sometimes it's just a misunderstanding. Sometimes the asthma care plan may be outdated and was never updated, but these are reasons that we want the parent to communicate back to their provider. And then we want to identify care coordination goals. So part of the caregiver survey is a needs assessment, looking at things that they might need in order to help manage their asthma. So for example, maybe they're having trouble getting a spacer or an air chamber. Maybe they're having trouble getting transportation to doctor's office, and that's why they never make their appointments. Maybe they're having trouble getting through to doctor's offices. So there are all kinds of things that we want to identify, and over the course of the 4 weeks, help them, empower them to solve their problems. The forms are listed, and we'll go over those in detail, but basically you're going to get a consent form, do the initial home assessment, asthma knowledge quiz, parent caregiver survey, and then we give community resources and the You Can Control Asthma book, which we will share with you guys. So the second visit is when we really start the education. We talk about asthma as a disease, signs and symptoms, common triggers, and how to avoid those, and proper use of roach and mice bait. At that visit, we give them dusters, mattress pillow covers, tiles, and that's for obviously for people. Again, we're focusing on the child's bedroom. So if the child's bedroom has really yucky carpet, or if they have carpet that you think can and should be removed, then we can give them tiles. We do give them a limit in terms of how long they can keep the tiles before they have to have them down or we take them back. So we have found that when we give them those directions that they're more likely to implement that. And we also do see that many of the families who rent just can't change it. So this is only about 1/3 of our families are usually able to do this. So it's not that many. And roach and mice bait and sponge and bucket. The sponge and bucket is given, and we talk about how they clean the baseboards. So that the baseboards, that's where the the roach dander, the dust dander is usually on those baseboards. And so what we ask them to do is to clean that every week, especially in the child's bedroom and where they spend most of their time. So visit 3 is when we really do an in-depth review of the asthma medication and devices. We train them on what the difference in control and rescue medicines are. We do the asthma action care plan, and we do care coordination. We give them at the time spacers and or masks. If they need they're less than school age, they usually still need the mask. For over school age, they can sometimes, and most of the time, use the mouthpiece. And then visit 4, we talk about school and daycare concerns. And this is all using the You Can Control Asthma booklet, so it's all there for you. We talk about exercise and fitness concerns, and again, continue our care coordination. So those goals that they've identified in visit 1, we want to keep addressing every visit to see have they met their goals. If they meet their goals by visit 3, obviously you don't have to keep asking about it. But many times it takes them a while to complete those goals. And then the forms for the last visit are the home assessment, knowledge quiz, caregiver satisfaction survey. So you can see on visit 2 and 3, there really aren't any forms. It's really just the first and the last that you need to get those forms. And then a follow-up phone call where you will just check in with them, address questions, concerns. And again, we do want to close that circle as best we can with the primary care provider. So we'd like for you to circle back to the primary care provider, especially if there's still issues like the child is still using albuterol every single day instead of the controlling medicine. If that's still a problem, we need to get them back to the primary care provider. So we assess the child's bedroom and general living areas. We tell them how to make simple environment interventions in their bedroom and general living area, and then we give the supplies to facilitate the interventions. At follow-up visits, we inspect. So when you go for 2, 3, and 4, you want to make sure that what you did at the last visit is still there. So if you put a mattress and pillow cover on at visit 2, then you just want to make sure, or if you gave it to them. Now, putting a mattress cover on is a 2-person task. It's really hard to do it by yourself, so we always tell the parents that. Sometimes they might ask if you can help them. We don't want you to do it for them because we're trying to empower them. But if it's a single mom who really has no other support, we would like for you to help them with that. You're going to, again, just note this at the follow-up visits. And at every visit, we also reinforce our education. So if you've talked about asthma medication, then you want to reinforce that. If you've talked about environmental interventions, you want to reinforce that. So this is just some pictures of what we've seen so you can kind of get a visual for what we're talking about. Here's baseline. You can see the carpet is crappy. This mother does have plastic, but not a real mattress cover or pillow cover on there. And you can see there's clutter all around. So we gave her these tiles, and she or someone did the labor for her. This is the mattress and pillow covers. And then here's another house with similar problems. No mattress or pillow covers, carpet on floor, and also had blinds, which you can't really see in the before, but afterwards you can see that we give them shades for their blinds if they want them. Sometimes they don't want them. Mattress and pillow covers, and we replace the carpet with tiles again. So this is a home with extensive water damage and mold, and we don't really have the funds to do mold remediation this much. If it's a little bit, we can teach them how to clean that, but when it's this extensive, it's really hard to do. What we have done in the past, though, is we have asked them if they can find someone to actually tear down the drywall and to repair that, then we would give them supplies. So we have done this, and this is like stage 1 of the repair. Here's a home where there's no drywall at all, so it's totally open to the outside. And we again gave them repairs, and they were able to repair that. So data collection is really important because we're all grant funded, and we have to give this data back to our funders. Sometimes it feels very overwhelming to try to do it all. So we really encourage community health workers to think of what will work for them, to have a plan before you walk in. This is when I'm going to do the data collection form, and this is the order in which I'm going to do it, because otherwise it can be really hard with kids running around and doing everything else. One of the things that we found that works is that when you do the introduction to the forms, just explain, this is why we have to do this. You can say the funders doing, we want to make sure this works. We want to make sure that that we are being effective in helping people with asthma, and we want to learn from your experience to make sure they understand why, and that works some of the time, most of the time. And then when we train on the forms, however, we create scenarios for which CHW should complete the form. So we'll say, well, this is a mother that has this, this, and this. What are you going to ask? Every visit each form should be attached to a visit. For this particular project, we just have the first and fourth visit with forms. Some projects we have every visit with forms. We script the way the questions should be asked. We buddy train in field with the experienced home visitors. So Typically what we do is we give the initial didactic training, which is kind of what's happening with this now. And then the second piece of that is to have the community health worker teach back to the group so that we know that they're familiar. And typically we focus on the medication class because that's the hardest one. And this is after we've gone through it in depth, clearly. And then once they feel comfortable with that, then they go out into the field and the supervisor observes them until they feel that they're comfortable, and then they're on their own. So that's kind of how we do the training. It's important to create a checklist for each visit. We don't have that in your binder, but certainly we can give you that if that's what you want. And then impromptu ride-alongs with supervisor. And then it's important to have data collection boosters on a regular basis. So especially for the form that's the longest, which is the first form, it's important for the team to just look at it together to make sure people are asking things the same way and that we're all interpreting it the same way on a regular basis. Here are all the forms. This is the protocol. The protocol should be first. Then you should have the home visit schedule and lesson plan second. Class handouts and educational materials, a referral form and letter to primary care doc, informed consent, which is not in there because we're still getting it approved because we had to rewrite it. Initial home assessment, asthma knowledge quiz, the parent caregiver survey, follow-up home assessment, caregiver satisfaction survey, and the patient caregiver follow-up survey. So what we will do is give Rachel probably one example of how forms match each visit so that then you can just create for everyone else. So the protocol is what we had to resubmit this just because we're doing expansion. And so that has not been totally signed off yet, but we think it will go forth, and so we have that in there so you can see it. The lessons plans, we actually have it visit by visit, and the community health workers along with Natalie work that out. The class handouts include some of the games we play, but also we have some handouts on asthma medication, so specifically Flovent or Advair, the ones that we use a lot, at least at CHOP. We have others on our website, so if you find, we don't have every medicine on our website, but we may have one that's not in the binder, so if you come across one that's not and you want to see if we have a handout, you just go to our website and print it out. It's very easy. And then the knowledge quiz and the initial home assessment are kind of done at the same time. And we repeat the asthma knowledge quiz again at 12 months. We also want to find out the caregivers are satisfied. So usually it's not the same person doing the intervention that's completing that. So either the supervisor or student, whoever, somebody who's not actually delivering the intervention should administer that. Here's some of the things that we've learned. We have to have educational boosters. Try to have them as often as we can. It's nice to have them every month if you have a team meeting. We need to make sure that community health workers have safety plans, and it needs to be multi-layered. So, you know, if this doesn't work, what do you do here? If this doesn't work, what do you do here? We've had community health workers witness domestic violence, child abuse. We've had community health workers caught in crossfires. So we just want to make sure we have a good safety plan. It's important to have daily contact with home visitors. Again, the whole scheduling and making sure we use the Outlook calendar, and we just have everybody put everything on the Outlook calendar and share it with everyone. So at any point in time, anyone on the team should be able to know where the community health worker is and how to get in touch with them. Many times our community health workers will, for the first visit, if they feel a little unsure about the neighborhood, will go with a buddy, or they might call one of their buddies and say, can you meet me here because, you know, this is a little strange and I'm a little worried. So we want them to have that ability to do that. And then the caseloads need to be clear, and we need to monitor it closely. So this is just to demonstrate what we've done and what we found. I'm not going to go through it in depth, but I thought it was good for you guys to see kind of what we do with the data. So this is a study where we had 208 children, and their mean age was 7.4 years. So most of them were school age, most of them were males, and most of them were African Americans, but we had a good number also Hispanics. And what we found is that most of them have row homes, most of them have gas heating. Some people use electric space heaters. Only half had air conditioners, which can be important in the summer, especially when there's a lot of humidity and mold. Everyone had upholstered furniture, which is a problem for dust, and about half had wall-to-wall carpet. Same in the child's bedroom. Very few people have pillow and mattress covers, so they're usually very happy to receive those. A lot of people have dust catchers like blinds, curtains, drapes, stuffed animals. And then we have a little checklist, I believe on this form, where you kind of check off and you say whether the assessment of the child's bedroom is poor, fair, or good. And we have some indicators, so you don't just pull it out of the hat like this means poor, this means fair, and this means good. And we can see that most of them are fair to poor. Nobody really was in a good category. And then the home was similar. We found that when we looked at the triggers, there were about 4 triggers at baseline, about 3.5 at follow-up. So the ones, it doesn't sound like a lot, but actually statistically is significant. And the ones that we find very easy is the mattress and pillow covers. The one we find very hard is the carpet, tobacco smoke, and animals. People don't want to get rid of that. But people do take steps to remediate. So we ask them at baseline, what things have you done to try to reduce triggers? You see about 2.5 things they've done, whereas at follow-up, they've doubled their efforts. So we do think that it's been effective in that sense. This is all of the clinical outcomes. So we reduce emergency room visits by 50%, hospitalization by 60%, missed school days by a day for any day, and about 2 days for asthma. And then we reduce their use of rescue medications, symptoms at day and night, and exercise symptoms. So this is how we use all the data that we collect. What we find also in interviewing our community health workers, that they value relationships over data. So we really, again, stress find that middle ground where you can empower families but still collect the data. We find CHWs very willing to be flexible in their scheduling. But many times, despite their best efforts, it takes longer than 6 weeks to get those 4 visits done because people no-show, not because of their schedule, because people no-show. And then if families have extenuating circumstances, community health workers have given them breaks and then try to get back in touch with them, and we found that to be effective as well. So, and we really value community health workers' feedback. We really emphasize, when we talk about this, I always emphasize how community health workers are probably the best recruiters, the best PR for your program, so you always need to respect them. We talk about it as a group, but when we're going to drop a family, it's community health workers' final decision. So we talk about the pros and cons, what's happening, but before we drop someone, the community health worker has to say they feel okay with that. And many times they don't. They hold on much longer than I would. So they're definitely the better people to make that decision. And then community health workers can make recommendations regarding incentives that will cause families to be retained. Self-management education. So the goals of asthma management are to reduce impairment, and that means to prevent chronic and episodic symptoms. And the symptoms usually are coughing, wheezing, shortness of breath, chest tightness. We also want to make sure they're not using their albuterol a lot. SABA is actually short-acting bronchodilators, and or beta agonists, sorry. And what we want them to do is not to need it because they're well controlled. So that's one of our goals. We want near normal pulmonary function test, near normal activity participation, and we really want to meet patient caregiver expectations. Sometimes their expectations are low, so we have to raise their expectations. And for example, they may be fine with the fact that their child's in the emergency room a few times a year. Some parents feel like they're doing the right thing by taking their child to the emergency room. So really, part of the education is saying, you know, we really expect that your child wouldn't need to go emergency room, wouldn't need to miss school, and we want to get them better so that they don't need to do that. We want to reduce risk. The more asthma exacerbations you have, the more likely you are to be hospitalized, the more likely you are to die. So that's a risk that we want to reduce. We want less emergency room visits and hospitalizations, and we want the best medication regime with the least side effects. Here are the self-management skills that we want to teach the families. One is to identify symptoms. Every child has their own constellation of symptoms. These can be the same over time, but sometimes they start off with maybe a coughing kind of issue, or they start with just exercise, and then it gradually becomes more often, more frequent. And so we want to help them identify what those symptoms are so that they can monitor them. We want to teach them how to identify and avoid asthma triggers. We want to teach them how to use the medications appropriately, how to use the devices appropriately, how to use asthma care plans appropriately, and when to call the doctor. So when we talk about self-management education, these are all the things that we're trying to accomplish. So the key points for lesson 1 are that we review the disease, and this is for the education piece. We review the asthma as a disease, and we try to figure out what they know. In visit 2, we're going to talk about asthma being controlled and being able to be controlled. We're going to talk about what their clues are, the warning signs of asthma. We're also going to talk about their asthma triggers and how you avoid that. We're going to then teach them about environmental interventions that they can make themselves. And these are simple interventions in the home to remove cockroach, rodent, and pet dander, as well as dust from the home. In lesson 3, we will focus on medications. We'll review the medications in the home. We'll make sure that they understand which is controller, which is a rescue medicine, and that they understand the proper way to use their devices. We will also, if they have an asthma care plan, we will review that with them. If they don't, we will help them create an asthma care plan to be reviewed by their primary care provider. And then in visit 4, we'll focus on exercise and fitness concerns because we want all children with asthma to be active. We'll also talk about how you communicate with your school nurse, how you communicate with your daycare provider, and we will give them a few more asthma intervention supplies. So now we're going to talk about asthma medications. So controller medications are medications that are used to control asthma. Typically, you use them every day. Most of them have some kind of anti-inflammatory process because asthma is an inflammatory disease. And most of these should be used daily, whether they're sick or well. Usually few side effects, but adherence is a problem because asthma is a disease that waxes and wanes. So what parents, if they don't see the problem, they don't understand why they have to use medicine every day. So this is a huge learning curve for families to realize that this is important for them to use every day. Rescue medications provide quick relief, and you only are supposed to use them when symptoms are present unless you use them to prevent exercise symptoms. They open up the airways and they relax the muscles around the airways. And they can be, and often are, overused. So when we talk about long-term controllers, the classes include corticosteroids, long-acting beta agonists, leukotriene modifiers, and immunomodulators. And these are used to achieve and maintain control of persistent asthma. Inhaled corticosteroids are kind of the mainstay, the gold standard of controller medication. They're most potent and they're consistently effective. They do have to be used every day to be effective. They're not medicines they can use for a little while and then the child's cured. So it's important for families to know that. there's the sensitivity and response to inhaled corticosteroids may be different among different people. So everybody doesn't respond the same way to every medication. And one of the things that we're learning about asthma that is a disease that may be expressed differently in different people. The side effects from using inhaled corticosteroids are oral thrush, but this can be prevented by rinsing your mouth out after each time you use it. And then if you use high doses of inhaled corticosteroids, it can reduce the growth. So long-acting beta agonists are used in combination with inhaled corticosteroids. We do not recommend that people with asthma use long-acting beta agonists alone. So the two products that we see a lot are Advair and Symbicort, also Dulera, and there are other medications which may be available. Sometimes as we think about controlling asthma, when the inhaled corticosteroid does not work, we do add the long-acting beta agonist to get control. Leukotriene modifiers are alternates. They are pills, it's known as Singulair. In children, most often, they're the alternative for treatment of mild-persistent asthma if inhaled corticosteroids for some reason can't be used, but it's not the first line. We do recommend inhaled corticosteroids first line. They're very safe as far as we know. And again, we find better adherence to this because it's a pill that can be chewed or swallowed. Doesn't require shaking, doesn't require priming, doesn't require all the other pieces. But usually it just doesn't work by itself. That's the problem. Short-acting beta agonist, albuterol, very commonly known. It opens the airways, and you can use it in a nebulizer, or you can use it with a MDI, which is, we'll talk a little bit later. The side effects for this can be increased heart rate, nervousness, muscle tremor, especially when it's overused. But even little children who get the nebulized dose will sometimes have a really marked increase in heart rate when using the albuterol. The devices are the meter dose inhalers, spacer devices, nebulizers, peak flow meters, and spirometer. So the MDIs deliver a fixed dose of medication. That's what's important. So when you spray it, it's a fixed dose each time. And this is a number of different MDIs. You can see they call them in all colors, sizes, and shapes, which can be really confusing for families when they have more than one. You always want to use your MDI with the spacer. Shake well before each puff. And after inhalation, you want them to hold their breath for a count of 10 seconds. And that's the thing that people forget, is the whole holding the breath for 10 seconds. Now for children who are less than 6, who may not be able to hold their breath, then we tell parents to count their breathing for 6 times. They need to breathe in and out 6 times. The best way to do that, we'll talk about in a little bit. And then you want to wait 1 minute between each puff. The spacer devices act as a breathing bag, which traps the aerosolized solution until the child breathes it in. So I think of it as a holding chamber. It holds the medicine there and is activated when you breathe in. Otherwise, it just sits in that chamber. And it removes the need for coordination, because when you use the MDI by itself, you really have to coordinate your breathing, your inhalation with activating the pump, and that's really hard to do. It can be used as a face mask or a mouthpiece. Dry powder inhalers are inhalers that have tablets that really just get crushed when you activate it. So you always want to make sure you hold it either horizontally or vertically, depending on the device. And the issue with this is that you need a really swift, deep breath. So children less than 12 many times can't do that.
Hi, we have some controller medicines. The first one I'm going to show you how to use is the Advair. This one comes in a disc, and what you want to instruct the parents to do, or the child to do, is to hold it so that the mouthpiece is facing them, so horizontally, almost like if they were eating a sandwich. So what they want to do is click, open it, and then this little trigger here is going to release the medicine. It's a powder, so you want to make sure that they're not playing around with the medicine, but they're standing still. So when they click here, they're going to be able to see the powder right in the mouthpiece. So they want to secure this, secure the mouth around the mouthpiece and take a fast and deep inhalation. Hold it to the count of 10 and then exhale. After they do that, make sure that they look at the mouthpiece and that there's no powder left in there. If there is, it just means that they didn't inhale strong enough. So you just instruct them to take the rest of the medicine. And then if they have two puffs, then they will need to close the canister up before they're able to take their second dose. Okay, and this one does come in 3 streams. We have the 100 over 50, 250 over 50, and the 500 over 50. They should never store it in the bathroom or in the kitchen. The moisture, since it's powder, the moisture will mess up the medicine. Okay. And again, kids over the age of 12 would be able to take this medication. And then this is our Flovent. It's also a controller medication. They take this on a daily basis to control their asthma. You want to instruct them to take it with their spacer. A child who's under 7, they would need to use it with the mask, okay? So what you want to instruct them is to shake up the medicine really good before using it, and it's going to fit right in the chamber. Secure the mask around the mouth and face. Do 1 spray and make sure they take 6 full breaths, okay? With this type of spacer, it has a little white lever there that's going to go up and down every time the child takes a breath. So they could either sit the child down in their lap and touch their stomach, make sure they take the 6 full breaths, or you just look at that lever and make sure it goes up and down 6 times. Okay, and then for the second puff, very important, take the medicine out and just shake it up really good again. And they should wait 1 minute before they do the second puff. An older child, they do not need the mask. They could just use the chamber with the mouthpiece. So for them, what you want to do, always make sure they shake up the medicine really good, put it in the chamber, secure the mouth around the mouthpiece, do 1 spray, and then take a deep and slow inhalation. Then want to hold it to the count of 10 and then exhale. Before they do the second puff again, make sure they shake up the medicine really, really good. Okay? And if they're taking this on a daily basis, usually 2 puffs 2 times a day, you want to instruct them to do it as soon as they wake up, and then before they brush their teeth, and then brush, just to avoid the thrush. And then again, same thing at nighttime. Take the 2 puffs and then brush their teeth before they go to bed. If they give them a hard time to brush, at least have them rinse their mouth off. This one you're not going to see very often. This one is Pulmicort. It usually comes with a lid. So what they want to do is just unscrew the lid and hold the medicine upright. This on the bottom, this part in the bottom, they gotta click clockwise. That will activate the device, and then anytime they want to take the medicine, again, click it clockwise. It's gonna release the medicine. Hold it to their mouth and take a fast and deep inhalation, and count to the count of 10, and then exhale. This is also a powder, so you want to make sure that they don't play around with it or they'll lose the medicine. And it usually comes with about 90 puffs in here. And again, no bathroom, no kitchen. They need to store it in a dry place. And very important, with each one of these, they need to rinse the mouth off after they use the medication. This one is your Symbicort. And with this one, you're going to use it the same way you do your Flovent. Just make sure that they shake it up really good. It goes with the spacer. And for older kids, deep and slow inhalation, hold it to the count of 10. And then we have our singular pill. And this one, they have chewable tablets that they can take once a day, either in the morning or at nighttime. And then we also have the ones that they swallow. And it usually causes drowsiness, so for most kids, they usually take it before they go to bed. And then we have your rescue medication. This one is Ventolin. Same thing as albuterol. And what you want to instruct them when they first pick this one up from the pharmacy, they all have a number indicator in the back letting them know how many puffs are in here. It's going to say 204. So the first thing they want to do is just shake it up really good and 4 sprays to the air. It's going to bring their counter down to 200, and it's ready for them to use. And then anytime they go to use it, all they need to do is just shake it up really good. They always want to use it with their spacer. Put it in there, 1 spray. If they're older than 7, take a slow and deep inhalation, hold it to the count of 10, and then exhale. Younger kids, you're always going to have them use the mask. And then anytime they put this medicine away for more than 10 days, because it's only as needed for cough, wheezing, anytime they put it away for more than 10 days, they need to shake it and force sprays to the air, okay? So they need to prime it. And then albuterol also comes like this for the nebulizer in a liquid form. We also have Pulmicort. This one is a controller medication. So sometimes if they have both for younger kids, they may get confused, so just make sure that you clarify. I usually try to stick with the shapes. Octagon is your controller medicine, and the skinny one would be your rescue medication. Yeah. And they all have expiration dates on here, so make sure that they look at the expiration date, make sure that they're not expired. Sometimes they have several albuterols, and they may be using one that is either expired or that doesn't have anything left. So this counts the medicine for them. So whenever it reaches 0, you're still going to have some spray in there, but it's not no actual medicine. Okay. We should be priming this medication when you first pick it up from the pharmacy and when you put it away for more than 10 days. And the reason why we prime the albuterol and not your controller medicine is because we're using your controller medicine every single day, so there's no need to prime it. The rescue medicine, we may be using it whenever the child gets a flare, so it may be put away for more than 2 weeks, and that's when you prime the medicine, okay? We try to use red and green dots to label the medications. Try to put green dots on the controller medicine just to indicate that they use it every single day, and the red dots on the rescue medicine because it's used as needed. And this is going to go along with your asthma care plan. The asthma care plan will identify the green zone as the medication that you use every single day, and that's going to be green. That's your green zone. Your red zone is where you're going to have your rescue medication.